katoa. He mihi nui, he mihi mahamana, kia koutou katoa. Welcome. Ko wai o. Ko takatimu ti maunga, ko aparima ti awa, no Isla Bank aho, ko te whanganui atara ti kaenga, ko pula, ko mua, me pula tuku ingoa, ko Peggy Rawa, ko Bill Oku Tupuna, ko John Takutane, ko Hannah Rato, ko Brody, ko Tom, ko Jack, na aku tamariki. Hei nihi taku mahi, ko Eileen McKinlay toko ingoa, no reira, tēnā koutou, tēnā koutou, tēnā tātou, katoa. Welcome everyone. It makes my heart sing to see all my loved ones and my colleagues and dear friends in the same room. And I thank you warmly for coming. And to my friends and colleagues online, I feel you and I hope you're comfortable in eating dinner at the same time. Modern healthcare systems need well-functioning interprofessional teams. So what do I mean by an interprofessional team? They are the different health and social care disciplines who care for you when you are ill or support your health and well-being. Whether we like it or not, we are all patients waiting in the wings. Google tells us the most well-known disciplines are nurses, doctors, and pharmacists, but the list of disciplines is ever increasing. Up to 50 different disciplines alone are classified under the umbrella term of allied health. Over time, patient care has become increasingly specialised and complex, as William said. Now we know that no one discipline can deliver all that is needed, and there is a huge benefit in bringing together the different specialisms. As Celia Davies, a renowned British sociologist, said 25 years ago, it's not what people have in common, but it's their differences that makes collaborative work more powerful than working separately, and that a diverse group could arrive at a place no individual or like-minded group could reach. So that's why it's important to have well-functioning interprofessional teams. But you might ask, don't health and social care professionals work in this way already? Unfortunately, not always, and some of you will know the Health and Disability Commissioner attributes a significant number of errors, incidents, and complaints about healthcare to failures in teamwork, often due to staff not speaking up when they see something is wrong. And perceived hierarchies between disciplines still exist, and equal credit is not always given to each discipline's knowledge and skills. The World Health Organization, WHO, issued a challenge in 2010 saying that health and social care disciplines could do a much better job of working together, describing this form of working as interprofessional collaborative practice, aka teamwork. They deduced when teamwork was humming, patient care incidents and accidents were reduced, patients reported greater satisfaction with care, and staff said they worked in a much happier work environment. The WHO posed the solution to improving a health professional teamwork as students undertaking interprofessional education, IPE for short, you're going to hear quite a bit of that, during their training to prepare them for teamwork. And following on from that, the 2019 amendment to the Health Practitioners Competency Assurance Act, which regulates most health and social care disciplines in New Zealand, instructed us to work together collaboratively and cooperatively. In my talk today, I will tell you about what I've learned about growing great interprofessional teams. You will not be surprised that this work comes from research teams I am part of, not just me myself. I will give examples from research into what good teamwork looks like in clinical workplaces, and 2, how to prepare health and social care students to work in interprofessional teams as graduates. This talk is framed around my 6 take-home points, and I hope this will have wider application to all of the teams we work with in all parts of our lives. A caveat before I start, everything I have learned about growing great teams is from being part of great teams. And without the teams I have been part of, this work would not exist. So a big thank you to each of you. First, a little about my experience in 3 of these very important teams. Team 1, whānau. My parents, Bill and Peggy Moore, met and married in Dunedin. Bill was the second youngest child, born to John Moore and May Drakeley. John came to New Zealand in 1902 on the Tongariro boat from Maguire's Bridge, Northern Ireland. He was a teacher, one of several in his family, and had been banished from Ireland, having fallen in love with a student. Yes, the family law says he bought a picture of his love and hung it in the family home after marrying May, who he met when teaching in Tuapeka Mouth School in Otago. May's parents, Arthur and Sarah, came to New Zealand in 1875 from England on the boat the Inaugural, their first child Maud dying on the trip. John climbed the ranks and became the principal of the Dunedin Training College. May was a self-taught archaeologist. Family holidays were spent at Karatani in Dunedin, where she excavated for flints. My father, Bill, who was very sporty at school, started training as a dentist, then swapped to theology and became a Presbyterian minister. My mother, Peggy, was the youngest of 3, born to Alexander Puller and Margaret Park. Alexander's father was born in Dunkeld, Scotland, and emigrated to New Zealand in 1860, coming out in the boat, the Pladder. Margaret, or Maggie as she was known, was the youngest of 9 children, her parents arriving from Scotland in 1859 on their boat, the Alpine, and settling in Waitati, Otago, where Maggie met Alexander. Maggie had been earmarked to care for the aging parents, and there was great opposition from the family when at the age of 32 she married Alexander in 1911 and immediately moved to Gisborne, so much so that Maggie's mother died 2 weeks after the wedding. When my mother was 7, her father Alexander, with his fair Scottish skin, developed what was called skin cancer, probably melanoma, and was brought back to Dunedin Hospital for last-ditch treatment, living only days after arrival. Maggie, who was all accounts a woman of determination, there being no widow's benefits in 1925 and still rejected by her siblings, managed to rent a large house at 589 Castle Street, it seems with an inheritance from an aunt in Australia, and she offered board to Otago students. My mother recalls that she and her 2 brothers were only allowed to eat the leftover food from the students. Peggy became a school teacher and taught in several primary schools in the Otago region before she married Bill in 1952. They moved to a parish in Isla Bank, west of Invercargill, and Peggy was called on occasionally as a relief teacher. My brother Bill and I were born in January 1957 and March 1958. Close in age, we got on well, and I remember always trying hard to catch him up. I recall an idyllic childhood with loving parents who devotedly served their isolated rural community and surrounded by paddocks, sheep, cows, and eating lots of silverbeet, turnips, and swedes from the garden. Life was simple. We did not own a fridge for many years, and the milk was dropped off daily by a local farmer in a billy, and my mother scalded and sometimes burnt it. The grocery van came once a week. My parents decided that Wellington was going to be a better place to educate their children, and we came in 1967, Dad taking a chaplain's role at Wellington Hospital and Mum teaching at Newtown School. Getting a minister's discount at the private Presbyterian schools meant Bill went to Scots College and me to Queen Margaret College. And my detention book records, I talk too much. I could have tried harder, and I was sent to the headmistress for saying bullshit in the era of Germaine Greer. I was happy to leave at the end of Form 6, Year 12, to start my nursing education at the age of 16 in the newly minted Alternative Comprehensive Nursing Program set up by Judith Christensen at Wellington Polytech, now Massey University. Our blue uniform set us apart from our hospital-trained nursing student colleagues, and we were scorned to begin with. Our class celebrates 50 years from starting our nursing education next month. I never wanted to be anything other than a nurse. My mother, having taught me to read at age 4, thought I was rather odd when I obsessionally read the death notices and obituaries. And she wondered why at the age of 14 I found a weekend job as a nurse aide. Luckily, before I graduated at 19, the law had been changed so nurses could register before turning 21. My first job as a registered nurse was in the acute medical surgical ward in a rural hospital in Dannevirke, now long gone. I returned to work at Wellington Hospital, eventually settling in the cancer ward, and then after 10 years to Mary Potter Hospice. In the cancer ward in Mary Potter Hospice, I experienced established interprofessional collaboration, nurses working together with doctors, dietitians, social workers, physiotherapists, occupational therapists, radiation therapists, and spiritual carers. John and I married in 1982. We both worked shift work, John as an air traffic controller and me at the time in the cancer ward. We built a house ready for our family and over 10 years had Hannah, Brodie, Tom and Jack. And my dad moved in to live with us after Mum died. It was a busy household and somewhat of a blur when I look back. My amazing children are my proudest achievement, and I regard being a mother as a great privilege. In 2024-25, after waiting patiently for 37 years, our whānau grew with the arrival of 3 mokopuna. Remy McKinlay Hannah in March 2024, Orla Lynn Connolly in May 2024, and Nora Betty Turpie McKinlay in March 2025. The 3 wee girls born within 12 months of each other. It's hard to imagine having more joy as John and I now revel in their developing personalities and of course their extremely clever developments. We equally admire the love, skill and dedication of their parents. Jack now has the title of Stellar Uncle. And on to Team 2, Primary Healthcare and General Practice Department. As this family grew, as well as undertaking postgraduate study, I worked as a clinical auditor for the Ministry of Health, a registered nurse and quality coordinator at Mary Potter Hospice, and eventually applied for a role at University of Otago, UOW, in what was then the General Practice Department, as a junior research fellow. I was hardly junior at the age of 42, but I thrived in my new team. Tony Dow, newly arrived from the UK and an inaugural professor in primary healthcare and head of department, was incredibly supportive, as was Debbie McLeod as research manager, and also the many colleagues since left, Sue Pullen, Chris Parkin, Joe Mecklam, Donna Cormack, Sue Vernell, Pauline Horrell, Lindsay McDonald, Selena Brown, Nita Hill and Carolyn Morris. I worked on soft-funded research projects for almost 3 years, thinking I would have to move on when each grant finished. Nothing has changed. And then I applied for a lecturer role when Tom Love left. My research interests have been broad, and generally speaking, this is a bad idea in academia, but probably influenced by my nursing background and enduring curiosity about people and their health situations. I have been lucky to work with researchers from Victoria and Massey University, Whitera in New Zealand, and University in Ireland, Norway, Sweden, and Australia. It was in primary healthcare and general practice and UOW as a whole that I encountered genuine interprofessional curiosity. There is huge diversity in staff backgrounds, and it means you can never assume what background another staff member may have. And it's been a delight to discover the full spectrum of health professional disciplines, as well as academics from sciences and social sciences, and staff with other specialisms, such as our fantastic librarians in photography, videography, and IT staff. And on to Team 3, the Centre for Interprofessional Education. At the end of 2021, I was asked to take a secondment to direct the Centre for Interprofessional Education, which is based in the Division of Health Sciences on the Dunedin campus. Our university teaches students in dentistry, dental technology, medical laboratory science, medicine, nursing, oral health, pharmacy, physiotherapy, radiation therapy, and social work. And in 2020, the university mandated these students receive 3 interprofessional education learning opportunities, incorporated at different levels of learning. so that they are teamwork ready on graduation. To do this, students of one discipline are deliberately taken out of their curriculum and brought together with 2 to 4 other disciplines in bespoke learning activities facilitated by specially trained IPE teachers. While I still sit in the Department of Primary Healthcare and General Practice, and HOD Lynn McBain is my trusted ear, my work now involves leading a committed team of academics and professional administration staff who work hand in hand, situated in the 3 campuses, as well as teams in Tairāwhiti, Gisborne and Greymouth in the South Island. Here is how the IPE Centre is arranged. The professional administration staff in blue are funded up to full-time to work their magic, matching timetables of different disciplines and from different institutions, and then creating classes with just the right numbers and mix of disciplines, and then finding rooms, as well as teachers, able to facilitate IPE at the exact time when needed. No mean feat. The academic staff in green are each funded a half a day a week, and their job is to persuade deans, head of departments, and academic peers that IPE is needed in their crammed curriculums. And that's tricky, and then to support these staff to learn how to deliver IPE. The 2 programs in Gisborne and Greymouth are 5-week rural regional immersion IPE programs. They're run by Otago University, but funded by Health New Zealand, and have their own locally based staff who I work with. In our most recent data collation, taken together, this great team arranged for the delivery of IPE learning activities to 2,400 Otago health and social care students and 700 students from other tertiary education providers. I'm extremely privileged to work with staff from 11 different tertiary education providers all over New Zealand to include some of their students from an array of disciplines in Otago's IPE. You'll realise it's very unusual for universities and polytechnics to work in such a cooperative way, but it allows us to benefit from including disciplines in our IPE activities that each of us don't teach. You might ask, what are these IPE learning activities and how do they enable students to learn about teamwork? Here are some examples of the learning activities that we offer. The mantra of IPE is learning with, from, and about. The learning activities must involve interaction, so students learn with other disciplines, including from them and about them. It is not passively sitting side by side in the classroom. IPE can be case-based learning, as in this classroom here. This is a class of Wellington-based students from Victoria University, so that's the midwifery students, and medical students from Otago University, and they're discussing human factors in maternity care. It can be a simulation of dementia care in Dunedin involving physiotherapy and pharmacy students from Otago University and nursing and occupational therapy students from Otago Polytechnic. In the Wellington-based Involve program under the auspices of the Wellington Interprofessional Teaching Initiative, this is a home visit to a person with long-term conditions, and the group is a medicine, physio and radiation therapy students. Or from the students in the Tairāwhiti and Titai Oputini IPE programs, these are examples of activities that the students get up to. Most of my work is virtual, and I spend a lot of time on Zoom, and I try very hard to write unambiguous emails, and I travel as much as possible to the various sites. My work is focusing on enabling others to do the IPE mahi. I have climbed onto tall shoulders from those who started this work, and I acknowledge Sue Pullen from UOW and Margot Skinner from the Dunedin campus. Today, Ashley Symes, Ainsley Peterson and Urdara Ramasinghe in the IPE Centre are integral to continuing this work with me, as is Sonia Morgan, who leads our research. A big shout out to my team, who I know will be mostly online. You are my greatest supports. And now on to what I have learned about growing great interprofessional teams. As mentioned, I will give examples into research into interprofessional teams in clinical practice and also from research on how to prepare students through IPE to work in these teams. Take-home point 1, growing great interprofessional teams takes time and practice. Just as great sports teams train together, so must health professional teams. So how does time and practice relate to great teams in clinical practice? Sue Pullen led a multiple case study using observational methods in general practice to determine if and how collaboration is achieved and maintained. In this study, research nurse Lindsay MacDonald observed clinical practice and joined team meetings in 3 practices and wrote detailed field notes for analysis. The study revealed the key elements which, when practiced, led to teamwork, including developing shared goals which enabled a positive team structure and climate. More recently, Chris Bartho has led a stream of work with a local general practice who are well recognised for excellent teamwork, serving a high needs population, and tracked over the year the care and volume of work with people with type 2 diabetes and which staff gave them care. The study demonstrated the huge amount of seen and unseen work with staff together undertaking the work with individuals and revealed the number and range of regulated and unregulated staff involved in the team. So how do we prepare health and social care students to work in these great teams? We researched our first IPE program in Wellington, which began in 2011, eventually called Involved, with the pioneer teachers being Louise Beckinsale, Ben Darlow, Meredith Perry and Ben Gray, all still committed IPE teachers. The descriptive evaluation research was led by Sue Pullen and then followed by a controlled trial led by Ben Darlow. These first studies led us to conclude that a brief 11-hour IPE program resulted in improved attitudes towards interprofessional teams and self-reported ability to function within the teams. But it was such learning sustained. Ben Darlow took up this challenge and went on to undertake a 4-year longitudinal study of the impact of IPE on graduates from the 5-week Tairāwhiti Rural program. He found graduates of this program had significantly improved attitudes towards healthcare teams, and these changes were maintained over the 4 years of the study. From that study, we felt now very confident that our interprofessional education was turning out teamwork-ready graduates. And recently we have published on how to implement these immersive 5-week rural programs using the Tita o Putini IPE program in Greymouth as an example. Take home point 2, great team players have excellent non-technical skills. So what are these excellent non-technical interprofessional skills? They are the skills needed to work effectively in interprofessional teams to communicate, collaborate, resolve conflict, make shared decisions, actively reflect on and then change practice, and to be ready to lead, but also to follow and support the leader. Some people call these soft skills, but most researchers agree that they are the hardest skills for health professionals to learn and must be taught and practiced. So what have we discovered about this? Fiona Doolan-Noble, now at Curtin University, led a study in a 4-week interprofessional placement and award setting at Dunedin Hospital. Her team examined if, how and when students acquired these non-technical skills and found students generally acquired them between week 2 and 3, as this was when the honeymoon was over and students encountered real-life clinical and interactional problems. This made us recognise the need for students to learn interprofessionally in clinical practice settings and, if possible, for sustained periods of time. However, this is difficult to arrange in clinical workplaces, and in Wellington we looked for other ways to provide interprofessional opportunities to students and found simulation to be effective. In this learning activity, actors played the parts of patients, and medical students and pharmacy intern learners described the simulation to be authentic and allowed them to practice their non-technical skills. In a current 4-country collaboration involving Sweden, Norway, New Zealand and Australia, I'm leading the New Zealand arm, where we have once again been using the observational method designed by Sonia Morgan to watch students as they work together in the IPE program in Greymouth and see how these non-technical skills develop. We have done a lot of squeezing into corners to observe what is happening between students, and this is proving a wonderful opportunity for Sonia Julie Myers, Linda Gulliver and myself to investigate how different IPE learning activities work. IPE facilitation is a very different skill than what teachers usually use to convey content knowledge to a unidisciplinary class, and we have designed a process to initiate new IPE teachers, which involves role modelling, inviting teachers new to IPE to join existing teams. And what can be learnt from research teams with teams in clinical practice settings regarding using these non-technical skills? Janet MacDonald at Victoria University led a study looking at the work of pharmacists based in general practice teams and found this new role added value by the pharmacists reaching out and responding to medicines information queries from other health professionals, as well as actively supporting the workloads of busy primary healthcare staff. John Kennedy, in his study of the care of refugee and migrant patients, found skilled and nuanced interprofessional teamwork was essential for comprehensive patient-centred care. Take home 3. Great teamwork is being truthful yet mana-enhancing. In clinical practice, teamwork by staff within services is complex, let alone when collaborating across a number of agencies. Sonia Morgan led a study in a youth health service looking at this interagency collaboration. It showed there were challenges to enacting cross-agency collaborative care relating to different worldviews. Some agencies had cultures that ran contrary to teamwork, and this created awkward and less than truthful conversations, likely leading to poorer outcomes for the young people who really needed this care. Within our IPE learning activities, we have found that supporting development of trusting relationships between students and between disciplines is very important, and our classes usually start with whakawhanaungatanga and often sharing kai to support building connection. However, unresolved conflict can occur when students work on interprofessional tasks, particularly those outside of the classroom. Conflict in itself is not bad and can be harnessed to gather a wider range of views which lead to better solutions. However, students need tools to resolve differences along the way. We found that using a brief intervention on conflict resolution within an interprofessional learning activity gives students the skills to do this. In another study, we examined students' responses to effective and ineffective interprofessional teamwork, and that we found that when students were exposed to poor teamwork, they were often put off in the future trying to work collaboratively. While we have no control over what students see of teamwork in the clinical workplace, it showed us that our IPE learning activities must be of high quality because if not experienced well by students, they have negative consequences. To this end, Ashley Symes implemented an accreditation process for our learning activities, a process which also enables a programmatic overview of IPE across student learning. Take home 4. Great team players embrace equity. In the international literature, teamwork is often associated with cultural safety and/or provision of equitable care. Personally, I think the 3 are conceptually different, but that good teamwork can foster equity. In clinical practice, Chris Bartho examined this in her study of prediabetes, which disproportionately affects those of Maori, Asian, and Pacific ethnicity. Her multiple case study found that the social determinants of health differentially influence patients' ability to engage with and respond to prediabetes care, significantly impacting the general practice's capability to work effectively with them, even when staff had already excellent teamwork skills. Ben Darlow's study of the pharmacist's role in supporting the management of knee osteoarthritis found that pharmacists were perceived by patients, regardless of ethnicity, to be welcoming, knowledgeable, accessible, trustworthy, and approachable. Given pharmacists mostly offer a no-charge service, this makes a big difference in supporting equitable care. The IPE Centre aims to offer learning activities that promote equity in health service delivery. This is usually through the incorporation of Hauora Māori in the learning activities and learning outcomes. In Wellington, we were very privileged to work with Shirley Simmons, Bridget Robson, Janine Stearmond, Bernadette Jones and others in the Irupamari unit to jointly offer a day one orientation IPE, with whakawhanaungatanga being the medium to bring new to campus students of different disciplines together. In Peter Gallagher's study of students in the IPE program in Tairāwhiti, where 53% of the population are Māori, we found the real-life exposure of students to this community was often transformative. Ben Darlow's study in the same program found a rural interprofessional immersion placement had long-term self-perceived impacts on students' desires and skills to work with Māori and embrace Māori models of health. Take home 5. Great teams include people patients. Including patients within a team when decisions are being made about their care seems logical, but does not routinely happen. Person-centred care is a central principle in Otago's IPE conceptual model, and the majority of the IPE learning activities focus on patients. Involving patients as the central participants in research and asking them to collect data about their own care explicitly values their experience and perspective. In this study, people with long-term conditions kept diaries of their health encounters and who they were with. Then we interviewed the health professionals they had recorded and looked at whether they engaged collaboratively with the other health professionals also involved. We found collaboration between health professionals varied, and there was a lack of clarity about leadership or care coordination, and that patients were rarely included in communication between professionals. Sue Pullen led a study looking at patients and health professionals' views of teamwork in general practice and found that patients with long-term conditions thought team-based care was essential, but there were differences in views between patients and health professionals as to who should be in the healthcare team and what their roles might be. This study was followed by several of our own, in which students in the Wellington Involve IPE program collected data on the social networks of patients with multimorbidity and whether or not general practice teams knew about the networks, and found often they did not and were missing out on rallying them to support patients when things went wrong. I have been fortunate to work with Sinead Donnelly in designing learning activities to help medical students talk to patients who are terminally ill in order for them to develop the skills to include patients in their future work. Take home 6 and you're getting to the end. Good teamwork requires a professional and an interprofessional identity. My professional identity as a nurse underpins everything that I do, but it is equally balanced by my identity as an interprofessional colleague. I have worked hard to be professionally agnostic. I admire what I think are the defining characteristics of my colleagues' discipline: the meticulous attention to detail of pharmacists, the courage, situational awareness and quick thinking of paramedics, the sensible and pragmatic solutions that occupational therapists devise to keep people independently living at home, the knowledge physiotherapists have about how to enable people to gain and regain their function, speech therapists who enable people to gain and regain the critical element of speech, social workers for their absolute dedication to equity and person-centred care, dietitians' skillful assessments of and provision of nutrition and knowledge of nourishing and affordable food, radiation therapists for their hugely technical skills coupled with sensitive kindness, and the sensitive and systematic but nuanced and gentle sleuthing by doctors to ascertain the right diagnosis and treatment. But more so, I am struck by the commonality of our caring. Once I thought caring was the province of nurses, but it is a universality of all of us. So what I'm saying is that we need to develop both identities, professional and interprofessional. My work has looked at both these aspects, including the work of research nurses in our university and how they use their nursing skills to ensure high quality research, process and outcomes, particularly in community-based research. My work with nursing colleagues Kerry Arcus from Whitireia, New Zealand, and Kathy Nelson from Victoria University in investigating innovative nurses' roles in the community. And most recently, I have worked with Deb Harris, New Zealand's first nurse practitioner, to write an integrative review of the first 20 years of nurse practitioner practice. Developing an interprofessional identity is an ability that largely comes after graduation, as new graduates gain skills in working every day in teams. But it starts with interprofessional education as a student. Our study showed the importance of and effectiveness of social learning in building professional and interprofessional identity when students of different disciplines lived together in shared accommodation. And for new medical graduates, we have written a chapter in Cole's medical practice on the value of working in interprofessional teams. Now I am working with other disciplines, like, for example, Mel Higson, who is a radiation therapist, to write about their interprofessional identities and their IPE work, to get the interprofessional word into new spaces. Recently with others, including Blenda Flood from AUT University on behalf of the Centre for Interprofessional Education and Collaborative Practice, we have worked with Sandy Gale and Sue Calvert from the government's responsible authorities established under the Health Practitioners Competency Assurance Act to develop a statement on interprofessional education and collaborative practice so that each authority could adopt it and use it for audit. It's about establishing a cultural change in practice in relation to teamwork, and it will take time. We all have a vested interest in growing great teams who are ready to care for us. So, in conclusion, you might ask what lies ahead. I'm not entirely sure, but I'm beginning to work on my succession plan so that somebody with fresh eyes can take IPE forward and build this cultural change. There are 3 Wimoko I want to have more time with. As you can obviously see, they're very alluring. But meantime, there is more work to be done. I have not yet achieved Otago University's goal of arranging 3 learning opportunities for each South and social care student, and I have a whole heap of other ideas for more research. I am also reassured that my advanced age is no barrier to learning more about growing great teams. Henry Oliver, in his most recent book on lengthy careers called Second Act, says, "Our lives, if they are well lived, are long works. Don't stop writing your story too early." Thank you, everyone.